Dr. Utkarsh Balani, first year DM endocrine resident, will be presenting a case of a 29-year-old male with episodic altered behavior. So, a patient, a 29-year-old male, resident of Varan, Rajasthan, farmer occupation, came to us with the complaints of episodes of altered behavior, sweating, palpitations, and dizziness since 2 years. Coming to the history of presenting illness, according to patient and his elder brother, patient was apparently alright around 2 years back, after which he started having these episodes. The episodes had an abrupt onset, starting with concentration difficulties and forgetfulness, progressively accompanied by irritability and instances of altered speech, as observed by his brother. During these episodes, patient also reported symptoms of hunger, dizziness, palpitations, and sweating. The episodes used to typically occur early in the morning or 5 to 6 hours after his last meal. There has been a gradual increase in the frequency of these symptoms, such that previously they used to occur once in every 2 to 3 months and has now progressed to 1 to 2 episodes every month since the last 2 months. Attendant as well as the patient lately noticed that the symptoms used to get better after eating something. The duration of these episodes were variable. Previously the episodes used to last for 1 to 2 hours, but since it has come to the attention of the patient that the episodes are getting better after eating something, so whenever he used to feel these episodes have started, he used to eat something and the episodes used to get better. There was no history of headache, loss of consciousness, abnormal involuntary body movements or in limb weakness. There was no history of neck swelling, any change in appetite or bowel habits or any proptosis. There was no history of fatigue, weight loss, nausea, vomiting or any recent change in complexion. As for the patient, there was no episode of any hyperventilation, feeling of impending doom, any trembling or shaking sensation. He even asked for chronic drug use or substance use, but it came out to be negative. We also asked the patient, we also tried to rule out certain cardiovascular disease as well as certain chronic kidney and liver disease, which can present with similar complaints. Past history, patient has a past history of acid reflux disease since the last 2 years, for which he is currently taking 40 milligrams of pantoprazole once daily and on SOS basis. Other than that, there was no history of any other comorbidity. Family history. The patient is one of the siblings from a non-consanguineous marriage who is currently 29 years old. All 3 brothers are married and have children. The eldest brother underwent an abdominal surgery in 2021, the exact details of which are not available with us. The father of the patient died in 2014 at an age of 58 due to some liver-related condition. Personally, the patient is vegetarian by diet, his sleep habits are normal, the bowel and bladder habits are normal, there is no addiction history, he is currently married and has 2 children. So to summarize the case, we have a case of a 29-year-old male who presented with 2-year history of episodes characterized by abrupt onset of altered behavior, accompanied by dizziness, sweating and palpitations, with these episodes typically occurring early in the morning or 5 to 6 hours after his last meal, with a recent increase in the frequency of these episodes since the last 2 months. There was also a recent observation of the symptoms getting better after eating something. So, what could be the possibilities?
The patient appears to have a palpitation, dizziness and sweating, which improves with eating. So, it could be a symptoms of hypoglycemia. Alternatively, as the episodic nature of the symptoms could also suggest excess of either adrenaline hormones or thyroid hormones.
So we have broadly divided the possibilities based on the system involved. So under endocrine causes, there can be hypoglycemia, thyrotoxicosis, pheochromocytoma and adrenal insufficiency. Under cardiovascular, there can be arrhythmias, mostly paroxysmal arrhythmias. Under neurological causes, there can be transient ischemic attacks and seizure disorder in the form of atypical seizures, and finally functional disorders like panic or anxiety disorder. So moving ahead, we went for general examination. On examination, we have a well-built, well-nourished patient having a BMI of 28.7 kg per meter square, having normal vitals and any absence of pallor, icterus, sinuses, clubbing and edema. On further examination, so can anyone from the audience take a guess what are these findings as written by the yellow arrow? And what about the ones with the red arrows? Anyone from Dharma? So these are basically acanthasis nigricans over the neck and axilla, and we can see multiple skin tags in the axilla and the back. Patient also, coming next image, we can see that the patient has central obesity. Also, if you look closely, there are multiple nodules around the umbilicus. These are multiple from well-defined skin-colored nodules over the abdomen, which clinically look like cholagenomas, but we need biopsy confirmation for that. Continuing the examination, on system examination, the nervous system and the cardiovascular system showed no significant findings. The respiratory and para-abdominal findings were also unremarkable. So to summarize again, we have a case of a 29-year-old male who presented with a 2-year history of episodes of altered behavior, dizziness, sweating and palpitations, with an increase in the frequency of these episodes since the last 2 months. On examination, he is overweight with central obesity, has skin changes including acanthosis nigricans, skin tags, and multiple firm, well-defined skin-color nodules which could be cholagenomas. So coming back to the differential diagnosis, based on history and examination, we were still not able to narrow down on differentials. As for the endocrine disorders, we needed biochemical tests to confirm them. For other systems as well, we needed further tests to confirm these findings. So we went ahead for the investigations. We did some routine blood investigations, in which complete hemogram, renal function test, serum electrolytes, and liver function test were all normal. Thyroid function test also came out to be normal, thus ruling out the possibility of thyrotoxicosis. Similarly, 8 AM cortisol levels were done, which came out to be within the normal range, thus ruling out adrenal insufficiency in this patient. Now, the random blood sugar was 102. Given the clinical background of the patient having central obesity and signs of insulin resistance, like acanthosis nigricans or skin tags, we went and we checked the HbA1c. Now, that also came out to be normal. Further, we did ECG and 2D echo for this patient, which came out to be normal. USG abdomen had no evidence of any adrenal mass. Some other tests were planned for this patient like EEG, Holter monitoring, and carotid Doppler, basically to rule out arrhythmias, seizure disorder, and TIAs. But as of now, we continue with the differentials. So with the differentials, with the investigations, we were able to rule out thyrotoxicosis, pheochromocytoma, and adrenal insufficiency. Given the clinical background of this case, we kept hypoglycemia as the first differential, arrhythmias or paroxysmal arrhythmias as the second differential, and the neurological causes as the third differential. Following which the patient was admitted for further evaluation. So based on history, examination and investigations, we decided to move ahead in a probabilistic manner for ruling out different possibilities as a cause of the symptoms. So first, we wanted to rule out or rule in hypoglycemia as a cause of the syndrome. So before we get further into the evaluation of hypoglycemia, we need to know a bit more about what happens during an episode of hypoglycemia. So our body has certain defense mechanisms in the form of counter-regulatory hormones, which get activated once the patient has hypoglycemia. The first line of defense is the inhibition of endogenous insulin production, which gets activated at the RBS less than 80 milligrams. Once the RBS falls below 70, the second line of defense kicks in and leads to the glucagon release. Further, if there is further fall in blood sugar levels, adrenaline, catecholamines, and cortisol is released, which is the third line of defense. Once the RBS reaches a value of 50, patient becomes symptomatic. At first, he has symptoms of hunger and autonomic symptoms like palpitations, sweating, and tremors, which make the patient wanting to eat something. At around RBS of 40, neuroglycopenic symptoms start to appear, which includes memory losses, confusion, irritability, or difficulty in concentrating. So, if there is a further fall in RBS, the patient can land up in coma or can have a seizure. So now that we know what happens during hypoglycemia, we went ahead and we did a test called the 72-hour fast test, in which the basic aim was to see if the blood sugar level fall with prolonged fasting. And if it does, then what happens to these counter-regulatory hormones? So during the test, we kept the patient in a fasting state. Only oral clear liquids were allowed. Patient also received continuous dextrose, free fluids. Glucose monitoring was done every 4 hourly till the RBS level falls below 70. And once the RBS level fell below 70, the monitoring was done every 1 hourly. Test was terminated after 72 hours if there was no symptom of hypoglycemia and at the same time the sugar levels remained normal. The test would be terminated sooner if the blood glucose level fall below 55 and at the same time patient would have the symptoms of hypoglycemia. Now we need to know why do we do this test after admitting the patient. So we have a suspicious patient having hypoglycemic episodes. We do not know when the next episode of hypoglycemia would occur. So in such a scenario, it is important that we somehow induce an episode of hypoglycemia in a controlled setting, and when the hypoglycemia hypoglycemia occurs, at that time we send some critical samples which include random blood sugars, serum insulin, C-peptide, blood ketones and serum cortisol. Another reason for doing this is that once the episode of hypoglycemia occurs, we have collected the samples, now we have to immediately correct the hypoglycemia by giving the patient dextrose. Also, there is one more important reason for doing the test in a controlled setting is to monitor the patient for any exogenous use of insulin or insulin secretagogues. So this was a 72-hour fast test of our patient. We can see that we started the test at around 6 p.m. Initially, the blood sugars were checked every 4 hourly, and once the value fell below 70, we started checking the blood sugars in every 1 hour. At about 41 or 42 hours, the patient started having complaints of altered behavior with palpitation and sweating. We checked the RBS, it came out to be 42. So at an RBS of 42, we sent the critical samples, following which, once the samples were collected, they were immediately sent to the lab for processing, and the patient was given dextrose for correction of hypoglycemia. Upon giving dextrose, the symptoms improved. So now we have a patient who was having symptoms of hypoglycemia. We have documented RBS of less than 55, and the symptoms got better after giving dextrose. So what is this trial? Can anyone from the audience tell?
Full strength.
So this is a Whipple's trial. So for proving an episode of hypoglycemia, we need to have this Whipple's trial. There should be an episode of hypoglycemia, there should be documented RBS of less than 55, and the symptoms should get better after giving dextrose. So now for a normal individual, ideally during the 72-hour fast test, there should be no hypoglycemia. But if a hypoglycemia is occurring, then we need to know whether the hypoglycemia is insulin dependent or insulin independent. So in our patient, we see that these are test results. As you can see, in an RBS of 35, ideally in a normal scenario, insulin and C-peptide should be suppressed. But in this patient, they were quite high. Also, we could see a normal response of the adrenals in the form of high level of cortisol. At the same time, ketone bodies were also negative. This signifies that the patient was having hyperinsulinism, because if there is presence of insulin in the body, ketone bodies production would not start. So with this, we were able to diagnose the patient as having endogenous hyperinsulinemic hypoglycemia. So once we have established that our patient had endogenous hyperinsulinemic hypoglycemia, we need to know a bit more about the various causes of hypoglycemia in an adult. So coming to the causes of hypoglycemia, we broadly divide the causes into two. First is the patient who is ill or a medicated individual, and second is the seemingly well individual. Now, given the clinical background, the history, the examination and the investigations, our patient fell into the second category. So for a seemingly well individual, the only cause was endogenous hyperinsulinism. Under endogenous hyperinsulinism, there were 4 differentials. First was insulinoma, second was insulin autoimmune hypoglycemia, third was radiodiagnosis, and fourth was insulin secretagogue. Now, for this patient, there was no history of any past gastric bypass surgery, and there was no history of any chronic drug use like sulfonylureas. So, radiodiagnosis and insulin secretagogue was ruled out. So, we are now left with only 2 possibilities. First is insulinoma, and second is the insulin autoimmune hypoglycemia. Now, before getting further, we need to know a bit about these 2 conditions. So, insulinoma is a benign tumor of the pancreatic beta cells, whereas insulin autoimmune hypoglycemia is a condition in which there is formation of antibodies against the insulin or the insulin receptors. Autoimmune hypoglycemia usually has some precipitating factors like chronic use of, there's history of chronic use of drugs like antithyroid drugs, alpha lipoic acid or proton pump inhibitors. So if we go back into the history, the patient had history of acid reflux disease, he was taking PPIs since the last 2 years. In autoimmune hypoglycemia, the symptoms of hypoglycemia usually start postprandially around 2 to 4 hours after his last meal, whereas for a case of insulinoma, these symptoms occur in a fasting state or in the post-absorptive phase, that is 5 to 6 hours, 36 hours after his last meal. In insulinoma, both the serum insulin and C-peptide levels are high in an equimolar ratio. Thus, the insulin to C-peptide ratio is always normal. Whereas in the case of autoimmune hypoglycemia, the insulin levels are high, but the C-peptide levels can be low or normal. Thus, the insulin to C-peptide ratio comes out to be high. On antibody testing, we can find antibodies in the case of autoimmune hypoglycemia. So, based on these findings, we suspected a patient to have an insulinoma. So, in view of young onset insulinoma in a male patient, we had to look for any syndromic association. So, we ordered the calcium profile for this patient, and we found that the patient had PTS-dependent hypercalcemia, thus leading to the diagnosis of primary hyperparathyroidism. Also, given that the patient is now a biochemically proven case of insulinoma and primary hyperparathyroidism, we did the skin biopsy of those lesions and found that the biopsy confirmed the diagnosis of cholangiomas. So, in a biochemically proven case of insulinoma and primary hyperparathyroidism, having biopsy-proven cholangiomas, what could be the first differential that should come up to our mind? Any of the audience? So we have a suspicion of Men-1 syndrome based on these given clinical findings. So now that we have a suspicion of Men-1 syndrome, we ordered some tests like pituitary hormonal profile, MRI SLR with contrast, and triple phase CCT abdomen. If we go back into the history of the patient, there was history of ancestral disease. So now that we have a proof of the presence of a single neuroendocrine tumor, we were suspicious of that there could be another neuroendocrine tumor. So we stopped the PPIs and we sent serum gastric for this patient. By this time, we also got the pituitary hormonal profile, in which we can see that the serum prolactin levels were raised, whereas the rest of the hormonal profile was normal. Now we did the MRI SLR with contrast and triple phase CCT abdomen. I would like to call Dr. Neerja for a discussion of the radiology.
Good morning. I am here to present radiological finding of this case. So CCT abdomen and MRI brain SLR was done, and these are axial images of the CCT abdomen in arterial and venous phase, showing arterial phase hyperenhancing lesion in the head of pancreas, which shows subsequent enhancement in the venous phase. This one is portal vein, and this lesion shows abutment with the portal vein. However, no infiltration was noted. These are coronal and the axial images showing two hyperenhancing lesions in the head of pancreas. One is the bigger one and the second is smaller one. There were two small or tiny hyperenhancing similar characteristic lesion was noted in the proximal duodenum, this one and this tiny one. There were few subcentimetric lymph nodes in peripancreatic, mesenteric and aortocaval region. These are venous phase showing few small subcentimetric, this one and this one, subcentimetric lymph nodes in peripancreatic region. The rest of the body and the tail of the pancreas appeared normal. So the summary of CCT abdomen findings are there were four hyperenhancing lesions, two in the head of pancreas and two in the proximal duodenum. So as the lesions are arterial phase hyperenhancing, possibilities could be a neuroendocrine tumor or the hypervascular metastasis. The next investigation is MRI SLR. These are T1 and T2 images of the patient, and these are T1 and T2 images of the normal for the reference, showing normal pituitary, the anterior pituitary and the bright posterior pituitary with its infundibular stalk and the optic chiasm. These are T1 and T2 images of the patient showing homogeneous lesion in the sella causing widening of the sella, and however its epicenter is within the sella, but suprasellar component was also seen, which seemed to avert the optic chiasm superiorly. These are coronal images in the post-contrast sequence. It is of patient and it is normal for the reference, and the lesion shows homogeneous enhancement. So the summary of the CT MRI brain was there was a homogeneous lesion in the sella region measuring 17 into 23 into 17 mm, causing widening of sella with enhancement in post-contrast sequence, and it's suggestive of pituitary macroadenoma. Now I would like to call Dr. Utkarsh to continue the discussion.
Thank you, Dr. Neerja, for enlightening us with the CCT and MRI scans in the patient. So we were having a suspicious case of Men-1 syndrome. We have already established that the patient had insulinoma, primary hyperparathyroidism, cholangiomas, and raised serum prolactin levels. CCT abdomen was suggestive of multiple pancreatic plus duodenal neuroendocrine tumors with lymph node involvement. MRI SLR suggested pituitary macroadenoma. By this time, we got the serum gastrin levels also, which came out to be very high. So with this, clinically, biochemically, and radiologically, we confirm this Menon syndrome, following which blood samples were sent for genetic studies. So we have a case of Menon syndrome. Having all of these findings, how should we proceed further? So based on the CT scan reports, we have multiple neuroendocrine tumors located in the head of the pancreas and the duodenum, along with multiple enlarged lymph nodes. Now, given the clinical background of Menon syndrome, there was possibility of presence of more such lesions in the pancreas. And additionally, based on history and biochemical tests, we have proved the presence of insulinoma and gastrinoma. So now it is very important for us to know which of these lesions are actually insulinoma. Because for the management of insulinoma, the primary indication is surgery, whereas for gastrinoma, it could be managed both surgically as well as medically. So it became important. So to solve this dilemma, we took the help of
You said PPH was high.
Yes.
Did you do parathorax scan or something for the neck?
So we had planned that, but not at that time.
Normally when we are dealing with a case of parathyroid Menon syndrome, actually we don't do any scan because the surgery recommended is to take out all 4 parathyroid glands. In fact, what we call as total parathyroidectomy with auto implantation. So we don't need to localize an adenoma. Whatever the scan shows, we need to go and operate and take out all the 4 glands because all 4 glands are parathyroid. And in fact, then most normal appearing gland needs to be auto-transplanted in the flora. So technically we don't need any scan for managing hyperpara associated with Menon. For sporadic hyperpara, it's a different story. We need to localize and then proceed about it.
I think similarly for the insulinoma and gastrinoma, there are pancreatic tumors. One needs surgery, the other may or may not need surgery, will be managed medically. So it would appear that surgery in any way is on the cards. So why try to decide or differentiate between the lesions? At least one of them is, or more of them could be insulinomas. And you wouldn't be doing only an enucleation. What sort of surgical procedure, how would that differ? Would you like to talk about that or later?
We talk about that later because it's more to come.
So to solve this dilemma as to which of these tumors are actually insulinoma, we took the help of molecular imaging. So in our patient, the next step was localization of insulinoma, which was done by using PET scan. So we had these 4 imaging modalities available. Out of these, FDG is a non-specific marker for neuroendocrine tumors, whereas FDOPA, DOTANOC, and excision scans are actually specific for neuroendocrine tumors. FDG may or may not be positive for a neuroendocrine tumor because of the low proliferation rate of these tumors. So hence it was not used. Second available tracer was FDOPA. It has ability for all the NADs but has a poor sensitivity, around 50 to 71%. So next available tracer was gallium DOTANOC. It again has ability for all the neuroendocrine tumors but has intermediate sensitivity, thus it was considered better than FDOPA. Recently, gallium-68 excision based PET CT has become available, which has ability only for insulinoma and has a sensitivity of around 94 to 98%. In fact, it has now become the gold standard test for localization of insulinoma. So based on this, we went ahead with DOTANOC PET CT followed by excision scans for quantification of neuroendocrine tumors as well as differentiation which of these are insulinoma and which of these are non-insulinoma.
Can you tell us what are the full forms of DOTANOC and excision? I'm not sure all of us know that. DOTANOC. Whenever you introduce a term for the first time, that is when you explain it, not at the end of the presentation.
I'd like to call Dr. Chintanya for discussion with company PET scan.
Thank you, Dr. Utkarsh. Good morning, everyone. I will be discussing the nuclear medicine findings of this case. As the CCT images were suggestive of pancreatic neuroendocrine tumor and with a suspicion of Menon syndrome, the patient was subjected to a gallium DOTANOC scan. Now, what is DOTANOC? DOTA is a bifunctional chelator which is used to bind the radioisotope gallium and the peptide ligand NOC. Now, DOTA peptides are somatostatin analog that bind all somatostatin receptors which are overexpressed on the surface of well-differentiated neuroendocrine tumors. We have 3 peptides available, DOTA-TOP, DOTA-NOC and DOTA-TATE, out of which TOP and NOC are diagnostic diagnostic ligand and DOTA-TATE is a therapeutic ligand. As DOTA-TOC, the full form of TOC is tyrosine octreotide, which is bind to a chelator, that is DOTA. Now, DOTA-NOC uptake correlates to SSTR density of the tumors, and we can see the physiological distribution of gallium DOTA-NOC in the pituitary gland, salivary glands, thyroid, liver, adrenals, spleen, and it is excreted through urinary tract. These are the MIP and coronal section images of the DOTA-NOC scan of the patient. We can see the physiological tracer uptake at liver and increased tracer uptake at the pancreatic region. These are the few representative axial images of the scan. In the first image, we can see intense focal tracer uptake at the head of pancreas region, corresponding to the enhancing lesion seen on the CECT images. In the second image, we can see two additional lesions in the body and tail of pancreas, and we can also see tracer-avid lymph nodes in the peripyloric and pancreaticoduodenal region. So at the end of DOTA-NOC scan, we have pancreatic lesion at the head, body and tail of pancreas. We also have tracer-avid lymph nodes suggestive of loco-regional spread of the disease. However, the two lesions at proximal duodenum seen on CECT images do not show DOTA-NOC uptake. In this scan, there was also a finding that is low-grade tracer uptake at enlarged right parathyroid gland was noted, supporting our diagnosis of primary hyperparathyroidism.
Now, that is the problem with scan, because we know in ME1 there is a hyperplasia of all four glands. But what will happen whenever we do a functional scan, it will go and get concentrated in the most dominant one or the most enlarged one. And it will give us an impression that it's actually solitary adenoma rather than involvement of all four. So that is why we generally don't do spatial scan. That is just a chance finding because we did it for other purpose. But we should always keep in mind that it can always underrepresent the disease in the case of ME.
Is there a possibility of superimposing your scan, this DOTA-NOC scan on the standard imaging? Because the non-avid lesions will not be visualized. So which one of the lesions you are seeing on the standard imaging is the active lesion? I mean, some kind of a superimposition is possible, that will be very helpful.
Sir, we did try that, but to get the same images every time, it's not actually possible.
What I can summarize, sir, the lesions which were visible, the largest one in the head of pancreas in the CT was clear-cut, showing a very intense tracer uptake in DOTA-NOC. That is the only thing which we found similar in CT and DOTA-NOC. In DOTA-NOC, we found two additional lesions in body and tail, and the lesions which were visible in duodenum were DOTA negative in this scan. That is the summary of till now the comparison of CT and the DOTA-NOC.
Since DOTA-NOC have shown multiple pancreatic neuroendocrine tumors, we need to decide whether we are dealing with a case of multiple insulinomas or a combination of insulinomas and other neuroendocrine tumors. So we went for gallium exendin scan.
So we can have a scenario of multiple insulinomas, we can have a scenario of insulinoma plus gastrinoma, or we can have a scenario of insulinoma, gastrinoma and non-functioning PNETs. And if we are dealing with an insulinoma, the idea is to take out all insulinomas. If we leave behind any single one of them, we will leave the patient uncured. So the differentiation of different tumor in terms of functionality is very, very important to decide about the treatment further which we are going to do in this patient. So then this role of this scan come into play.
Exendin 4 is a GLP-1 analog which specifically binds to the GLP-1 receptors on pancreatic beta cells. Insulinoma has higher expression of GLP-1 receptors, and gallium exendin 4 PET-CT can be used for identification and differentiation of insulinomas from other neuroendocrine tumors. This is the representative images of the gallium exendin PET-CT of this patient. As we can see, there is low-grade physiological uptake at liver, and we see the tracer-avid lesion at the head of pancreas with no other tracer-avid lesions in rest of the pancreas. Based on the comparative analysis of DOTA-NOC and exendin images, we conclude that other than the head of pancreas lesion, all other lesions which were seen on DOTA-NOC scan but not on exendin scan are non-insulinoma neuroendocrine tumors. the Dr. Utkarsh.
We still haven't got the full form of DOTA. It's a chelator grade. It's
Yes,
supposed to
sir.
be a full form of DOTA. And exend is, what exactly is exend?
Extended is a
What does your told us?
TOC is basically nothing but tyrosine octopeptide. These are all TOC, TATE, NOC are all somatostatin analogs, which goes and binds to the somatostatin receptors on any neuroendocrine. And there is DOTA or NOTA. There are multiple now chelators that are available, which are used to connect the radioisotope, that is gallium-68 or lutetium, depending on the purpose which we are using, to this peptide of octopeptide analog. And second is exendin. Exendin is very important. Exendin is being used as a drug, famous drug, which I think everyone of us know, is semaglutide. It is basically nothing but a GLP analog. GLP-1 receptors are present specifically on beta cells of the pancreas, and we are just exploiting that property. So we are attaching gallium-68, which is radio tracer, to the GLP-1 analog, which is an exendin. It goes and binds to the beta cells of the pancreas. So any tumor which is coming out from beta cells, it will light up on exendin scan. It will not be present on other neuroendocrine tumor cells. So that in that way, it will be able to differentiate an insulinoma from a non-insulinoma neuroendocrine tumors like gastroenoma and maybe non-functioning entities which are present in almost 50% cases of MEN.
Thank you, Dr. Chintanya, for walking us through PET-CT findings. So we have a case of a Men-1 syndrome having insulinoma in the head of the pancreas, gastrinoma probably in the duodenum, probable non-functional neuroendocrine tumors in the body and tail of pancreas, with asymptomatic primary hyperparathyroidism, macroprolactinoma, and multiple cholangiomas. So how do we manage this patient? So coming to the management plan, macroprolactinoma, the plan was to either go for medical treatment, since prolactinoma is a dopamine agonist sensitive tumor, versus to go for surgical excision. For primary hyperpara, the plan was to either go for immediate intervention or periodically monitor the patient every 3 months. Coming to the management of enteropancreatic neuroendocrine tumors in the case of Men-1 syndrome. So the challenge of management of Men-1 related enteropancreatic neuroendocrine tumors is achieving a fine balance between treatment-related morbidity and disease-related morbidity. So we need to make a decision between removal of as much disease as possible with the aim of curing the patient, and at the same time preserving enough pancreatic tissue so that the patient does not land up in pancreatic insufficiency. So depending on the patient's disease burden, we can either go for a relatively less extensive procedures like enucleation or distal pancreatomy, or to go for more extensive procedures that is Whipple's and rarely total pancreatomy. So for this, we went ahead and did a multidisciplinary team meeting to discuss the final management of this patient. So final management was planned as such for multiple pancreatic neuroendocrine tumors, pancreaticoduodenectomy with intraoperative ultrasound, plus minus enucleation of body and tail lesions, plus locoregional lymph node dissection. For macroprolactinoma, since the perimetry was normal in this patient, medical management was advised using dopamine agonist. And for primary hyperpara, periodic surveillance was chosen as a line of management. Now I would like to call upon Dr. Anand Nagar sir for discussing the surgical management of this patient.
Good morning, sir. Regarding the, as we know the complete diagnosis of this patient, so we, the diagnosis duodenopancreatic neuroendocrine tumor with local regional spread. So our plan was surgery in the form of either conventional surgery, which requires a large incision in the form of either Mercedes-Benz or the modified Makochi incision, or the minimally invasive surgery, which can be laparoscopic or robotic. So we plan this patient laparoscopic surgery for this patient. As in, we can see the diagram in the image. First, we did the staging laparoscopy to look for the local spread or the distant spread of the disease. But our plan was that if the patient is having distant spread, we still go and operate this patient, because this patient is having hypoglycemic symptoms, which will be cured only by surgery only. So we proceeded with our next plan of the laparoscopic mobilization of all the this procedure. So we did string laparoscopy followed by laparoscopic mobilization, and after the mobilization of this, we can think of we think around in our mind that this process can be done total laparoscopically or total robotically also. But as we know, this patient is having two lesions in the body and the tail of pancreas, which requires intraoperative ultrasound in the form of either laparoscopic ultrasound or an open incision and take an intraoperative ultrasound with the help of our radiology colleagues. So we we took a midline incision and we did this intraoperative ultrasound to localize the lesion in the body and the tail of pancreas. We can see the hypoechoic lesion in the head of pancreas, large lesion in the head of pancreas, but there was no lesion in the body and the tail of pancreas. As we were seeing in the DOTA study, there's showing the two lesions in the body and the tail of pancreas. So what we did, as we have discussed, if we are able to find a lesion in the body and tail, we enucleate simultaneously, but there is no lesions. So our plan was to do a pancreaticoduodenectomy, and we did this procedure with the initially followed by minimally invasive. Then we converted the midline incision, and we completed this procedure with both of the approach. The recovery of the patients is around discharge around 5 to 6 days, and this is the short our experience we have published in the literature regarding our we have operated insuloma in our department with the help of endocrine. Till now we have operated 12 patients of insuloma, in whom we have done 4 enucleation. In 4 patients we have done pancreaticoduodenectomy, and the 5 patients we have done distal pancreatectomy. Thank you. For the further discussion, I would like to invite Dr. Utkarsh.
Thank you so much, sir, for taking us through the surgical management of this patient. So we have to discuss the perioperative course of the patient. So in this chart, we just wanted to highlight that once the insuloma was removed, even after stopping the dextrose infusion around 2 to 3 hours back, once the insuloma was removed, we can see there was a gradual increase in the level of sugars. So this is important in a case of Meniere's syndrome, because a Meniere's syndrome patient can have multiple insulinomas, and the rising level of blood sugars is an indication of completeness of surgery.
This is even more important in this case because we were not able to find those two lesions in body and tail of the pancreas. Because if those tumors would have been functional, and if we even we do the such extensive procedure like because we may land up with uncured patients. Intraoperative sugar monitoring, it's a very good tool that can be used in these multifocal disease scenarios. Insulin has a half-life of just 3 minutes duration of action. So as soon as we take out the insulinoma, sugar start rising within the OD, and the trend of the sugar can tell you that we have done our job completely or not. If the sugars are still remaining low, even after ripples, we may sometimes, in some of cases, we may have to end up with more expensive surgery, like rarely
This is where the role of excited scan comes into play, because that was only single lesion shown on excited scan. And intraoperative ultrasound, even if the 2 lesions were seen, many a times you are not able to localize those 2 intraoperative. So intraoperative ultrasound is equally important, one of the modality to find out if you are missing out any lesion in the body and the tail. And sometimes if you do visualize it, then obviously you need to take them out.
In this case, you had the lesion in the head seen. Functionally, there were 2 lesions in the tail, and that was the reason for doing a Whipple's.
No.
Duodenal lesions were there, but what about the tail lesions? I thought they were picked up on the duodenal scan.
So they picked up on that's the issue which we are going to deal. But the problem is that now it was a constantly evolving scenario. We had a tumor which was not visible on the CT, then we had a rotanok which showed those tumors, then in top ultrasound we do not have those lesions, right? So we need to take a call what we need to do, and there the dictum comes into play, how much we should intervene. So if we are not able to palpate those lesions, we cannot do the enucleation, we will end up with distal pancreatectomy. Now we have taken already the ripples. If we do distal, then how much pancreas is going to be left behind? So it's a decision which we surgeon and the
false positive Dotanox scan, do you think?
I cannot still say it is false positive. It can be still positive. We have last week only seen a patient where CT was initially reported negative. Dota showed the lesion. Intraoperatively, we were not able to palpate the lesion. We did distal pancreatectomy. Histopathology actually showed the tumor. So we cannot still say it was negative. We need to see, and time will tell us it was positive or negative.
So here the question comes is that we do a total pancreatectomy because it will amount to removing the head, body and tail, everything. So it's a total pancreatectomy. So you will end up with the morbidity of total pancreatectomy. It is not only pancreatic insufficiency which you are worried of in total pancreatectomy. Suppose everything goes off surgically well. In fact, doing a total pancreatectomy is simpler for the surgeon than doing a Whipple's procedure because there is no pancreatico-enteric anastomosis. That is one of your Achilles heel in Whipple's, which if there is a leak, the morbidity and mortality in Whipple's is because of the pancreatico-jejunostomy or pancreatico-gastrostomy leak. So if you do a total pancreatectomy, there is no anastomosis, there is no leak. But what eventually the patient ends up is brittle diabetes. So that is where the patient has got
Absolutely brittle. It's nightmare for
yes. So
because in type 1 diabetic we have only insulin deficiency and we know how difficult it is to make. And here we have a insulin and glucagon deficiency. So 1 unit extra insulin will lead to hypoglycemia and 1 unit less will lead to hyperglycemia. So it's a nightmare for management.
But you might wind up having to do that now if on follow-up the lesions are become clinically manifest.
Limited to enucleation whenever they will be visible. We will not do so.
again you can so doing a total pancreatectomy vis-a-vis leaving it because they were not positive on exit scan, probably they are non-functional peanuts, and that's our assumption. Now that is what we were discussing. The question is, do you want the patient to be subjected from hypoglycemia to doing a total pancreatectomy, the morbidity and going into a brittle diabetes, or leaving that those two lesions which are not visible and hope, and the way they are non-functional peanuts, they may not cause any issues to the individual.
What about the RFA? If you do an RFA on the other lesion,
If you are able to visualize it on intraoperative ultrasound, then RFA is a good modality. But again, doing it in pancreas is a little bit of a concern, because if it is close to the duct and you end up burning the duct, you may cause pancreatic leak, which is directly into the abdomen. That again will be a disaster.
Continuing with further management, for prolactinoma, we started the patient on dopamine agonist, that is cabergoline, at a dose of 0.5 mg per week. And for primary upper para, we kept the patient on periodic surveillance. Every 3 monthly serum calcium and BTS levels were done. The remaining post-operative course of the patient was uneventful, and following which he was discharged on POD 7. Now I would like to call Dr. Aditya sir for discussing the histopathology of the patient.
Thank you, Dr. Utkarsh. Very good morning to all respected teachers and fellow residents. I'm Dr. Aditya Mundra from the Department of Onco-Pathology, and I'll be discussing the histopathological and immunohistochemical aspects of this particular case. So we received pylorus preserving pancreatoduodenectomy specimen, and after thorough examination of the specimen, we observed 2 tumors in the pancreas and the duodenum. The tumor in the pancreas, the greatest dimension of the tumor in the pancreas was 2.2 centimeter, and in the duodenum was 0.8 centimeter. The other specimens received were common hepatic artery lymph nodes, middle colic artery lymph nodes, lymph node in proximity to the unsmeared process, and the hepatoduodenal ligament lymph nodes. Microscopic examination of these lesions revealed that the tumor cells were present in trabecular and insular pattern involving the pancreas, as we can see the normal ascena of the pancreas over here. Similar tumor was also involving the duodenum, as we can see the Brunner's glands of the duodenum over here. This tumor was also involving the regional lymph nodes, and high power examination of this revealed that the tumor cells were round to oval in shape, had moderate amount of eosinophilic granular cytoplasm, round nucleus, and stippled chromatin. So all these features are of neuroendocrine tumor. So to confirm these findings, immunohistochemistry was performed, and these tumor cells showed cytoplasmic dot-like positivity for pancytokeratin, cytoplasmic positivity for synaptophysin, nuclear positivity for INSM1, and the Ki67 proliferation index was less than 3%. So the final diagnosis was well differentiated neuroendocrine tumors grade 1. Multifocal tumors were seen, 2 in the pancreas and 2 in the duodenum. The mitotic activity was 1 per 2 mm². All resection margins and pancreatic surfaces were free of tumor. 4 by 12 lymph nodes were metastatic tumor deposits of neuroendocrine tumor grade 1. and a pre-TNM stage for multiple tumors were given as PP2 and 1.
This whole day. So ultimately those two lesions in duodenum actually turn out to be NET. And now we can say probably those NETs are gastrinomas which were leading to those symptoms. Another thing is in pancreas also the largest lesion was appearing rota avid, but there was small lesion beside that. On the CT scan, if you can recollect, that also turned out to be NET, which was also not palpable during surgery. So what I mean, I just want to suggest, so we need to actually going by one single imaging rather than it's a more of a collating the data from all imaging modalities and then critically analyze them and decide that.
Did the gastrin levels come down after this? Not done as yet.
Now operated.
You just make it up. So, is this a malignant tumor or what do you call? I mean, would it be? It's a grade 1 lesion. Would you treat it like a malignancy, or you would assume that surgical resection is sufficient?
So, gastrointestinal and pancreatobiliary neoplasms, the neuroendocrine tumors of the pancreatobiliary tract and the gastrointestinal tract, they are broadly classified into neuroendocrine tumors and neuroendocrine carcinomas. The neuroendocrine carcinomas are known to be malignant, sir, but tumors.
So they are also malignant. Their behavior is malignancy. We cannot define whether it is benign or malignant.
So I think this question.
Differentiated tumors are also supposed to metastasize. This has been metastasized.
This dissociation is well defined.
I have a question. Like, can you histopathologically differentiate the insulinomas from gastrinomas from other tumors?
We can do that. We can do that.
You do immunohistochemistry.
We can do.
We cannot do it on the basis of histopathology only because only some points are there like in insulinoma, amyloid person is seen, in stomatomas, samoma body is seen. No other any specific pathological feature is there to differentiate between them. It is done on the basis of serum levels.
Just on.
We have ISC markers available for serum insulin, glucagon, and gastrin. We can do those ISC. Of course, they are not available in India.
But not on histopathology. But not on histopathology. On IC.
On ISC.
And one more thing I want to add here, sir. It is very important for a pathologist to get the clinical correlation of the patient. In the duodenum, we were not seeing any nodule, anything. We just gave random sections on the basis of clinical clinical things that there was some it is not there grossly nodules were not seen. It is only on the giving random sections from the duodenum we identified two nodules from the duodenum.
So no denying that full clinical information has to be given to the pathologist and preferably a one-to-one discussion.
But I think this dissociation is very well described. Even grade 1 can have metastatic disease. The first treatment is good surgery, and after good surgery, if we do not see any evidence of metastatic disease in terms on functional scan as well as on biochemical parameters like homogranin, we can actually consider it as cure. In case of men 1, we are actually more worried about the recurrent lesion that are keep on coming back.
This is also important to the K6 index should be put and it should be graded on the metastatic side also because many a times there is a discrepancy between the primary and metastatic levels.
Thank you. Now I'll invite. So this is a pictorial representation of Victor's resections. Pylorus present.
We have a lot of people who are still awake. So.
I hope you try. So just to summarize whatever we had just now. So this is the genetic analysis report which we sent for this patient, which ultimately proved that patient had a mutation in exon 11 of menin gene, which is responsible for MEN1 syndrome. Full genetic counseling by our medical genetist was provided to the family so that he has 2 other siblings as well as he has 2 offsprings also, so those should be screened and managed accordingly as per the mutational status. This is the future plan for the patient. In terms of duodenopancreatic entities, as we just discussed, that there are two still remaining unsolved puzzle. We need to follow it up, and there is always a possibility of other lesions coming back. So good periodic surveillance is required. Prolactinoma, we have started with medical management. We will up titrate the dose depending on the prolactin level as well as radiological remission. In very few cases, there is a dopamine resistance. Then we can ask help from our neurosurgeons to debug the tumor. When it comes to primary hyperparathyroidism, it is right now asymptomatic disease. We have a very clear guidelines when to intervene. Then only we will be able to intervene. But whenever we will intervene, it will be full total parathyroidectomy with autoimplantation. It will not be a solitary gland removal. Now, this is the summary of MAN1. I will not go into detail. These are different affections. This is the algorithm of insulinoma localization that has evolved over the years with different sensitivity, specificity. I would rather, that is what I learned during my small learning career, that one, we should go always by multi-modality treatment. In functional imaging, there are very much false positive and false negative in terms of physiological uptakes and other things. And sometimes the finding of CT do not correlate well with functional imaging. So it's a collation of data, of information derived from multiple imaging modality, which should be backed up by a clinical input, and then we should need to take a call what to do, what not to do. And conditions like MAN1, it is always a question of how much to intervene, when not to exceed the morbidity, which is because of the disease compared to what because of the treatment. These are the standard practice guidelines. Wherever when we diagnose a MAN1 patients, the screening starts from 8 years of age, and then there are set protocols how should we follow them up based for pituitary, pancreatic, and parathyroid involvement. Last but not the least, why we selected this case? So we tried to went back and see the literature whether it has happened ever. So I just came across these two case reports. One was published way back in 1980s or something. One was published in 2008, where there was a report of having two different clinical syndromes like gastruloma, insulinoma in a single patient at the same time in a case of MEN1. I could not find, to my best of knowledge, more information than this. So the rarity of the case, novelty of the case, and the innovative use of those modalities, they have never been tried. Exendin scan was supposed to be better sensitive, not to be so more sensitive than and then the Rotanox scan. That was used to be the rule, but it has never been used to differentiate. Or I think in literature there has been no description of this additional utilization of characterization of different tumors in the same patient in the same setting. So that is what this case makes it a novel case. And of course there was a complex and ever evolving scenario. एक में positive है, दूसरे में negative, फिर तीसरे में positive, फिर negative, and ultimately OT में फिर negative. So it was a difficult thing for us, but where we need to balance the morbidity of treatment and the disease itself. So that is why we selected this case. And in the end, I would definitely from our department side like to thank all the contributing department, radiodiagnosis, nuclear medicine, HPB surgery, onco-pathology, neurosurgery, and anesthesiology for their extreme help and contribution in solving this puzzle. And with this, I will end today's discussion. Thank you.